Vascular closure devices for evidence-based nursing practice, presented by Jordan Wood. Introduction. So what exactly is a vascular closure device? A vascular closure device is used to gain hemostasis post-invasive procedure. It is essentially composed of three aspects that are inserted into the femoral artery. They include a copolymer anchor, a collagen sponge, and a suture. The picture to the right of the screen is an example of one of the more popular vascular closure devices, the angioseal. As you can see in the picture, the anchor is located inside the femoral artery. It anchors the collagen sponge, and then in the dermal space is the suture. So what kinds of procedures would you actually use a vascular closure device? Vascular closure devices are usually used in invasive procedures where access is gained to the femoral artery. These include procedures such as a cardiac catheterization, a lower leg revascularization, an aortogram, procedures that are invasive and require access through the femoral artery. What are the other options when closing a vascular access site? Generally speaking, if a vascular closure device is not used, it can be performed with manual compression after a sheath is removed. Usually either a 5 French ranging all the way up to an 8 French sheath is inserted into the femoral artery. The procedure is performed. Then post-procedure, after all of the wires and stents and everything else has been removed, you still have a sheath that is inserted into that artery. Patients that are left like that have to be monitored from anywhere from 30 minutes to 3 to 4 hours until their coagulation factors indicate that the sheath can be pulled. Once the sheath is pulled, manual compression is applied for usually between 10 to 15 minutes, depending upon what facility you work at and what the protocols are for that facility, in order to achieve hemostasis. So just to give you an overview of the problem, there's no standard with which a VCD is used or not used, at least in the facility where I am employed. It can vary widely between interventional cardiologists, vascular surgeons, or general surgeons. It's important that they have all of the information that is available in order to make an informed decision for their patients, because we want to advocate for the patient and we want them to have the best possible outcome. When so many different clinicians have so many varying opinions on closure devices, it's hard to get a grasp on what will be done at the end of a procedure. If there was some form of standardization, if the patient was a viable candidate for a closure device, then it would allow the patient more comfort before the procedure because they would know exactly what's going on, rather than having the physician say, well, we're going to go in and we're going to see what it looks like and we're going to try to put a closure device in, but these are the risks of a closure device, and if we're not able to put that in, then we're going to have to keep you here for another 3 to 4 hours. And it just doesn't allow for a lot of transparency when dealing with the patient. Because while the procedure is being done, the patient is not in a state in which to understand everything that's going on. The PICO question for this evidence-based nursing practice study is, are invasive procedure patients who have closure devices inserted compared to those without closure devices at increased risk of post-operative complications? So essentially, what are the benefits of using a vascular closure device, and what are the drawbacks? Are there more positive outcomes with vascular closure devices or with manual compression? All of these we hope to answer in this research study so we can draw conclusions and update best practice. Theory. So now that we have a PICO question and we have an area that we would like to research, it's very important to select the right theory for your evidence-based practice. The constructivist grounded theory allowed a large amount of freedom for the researcher, because instead of information defining what categories you had. The categories were defined by the information that was available. So instead of saying that you were going to have 15 patients this and 15 patients that, you were able to allow the patients to undergo the procedure and then have them put into categories that fit the data. The constructivist grounded theory is composed of sampling, coding, analysis, theory, and writing. And all of this is in a cyclical fashion, so as you receive new information, you have the ability to put it into the theory, and it just rotates it out to provide best practice. Literature review. So when reviewing the literature for this presentation, I used a variety of sources which included Galileo, research that was available where I work, and Google Scholar to find credible research articles that I could use. While using Galileo, I restricted the parameters to 2011 to present and full document PDF so that I wouldn't get an abstract of the information, but I would get the full article. This created only pertinent information to my topic, but it did limit the amount of research that was available to me. The major findings of this research was that vascular closure devices did decrease the risks of post-procedure complications. However, it did increase the risk in 2 of the studies for retroperitoneal bleeding. Retroperitoneal bleeding is a very severe complication. It is important that patients are monitored for signs and symptoms of retroperitoneal bleeding so that these signs and symptoms can be treated. One of the other themes throughout the research was that there was a lack of differentiation as far as other factors that would complicate post-procedure, such as obesity, diabetes, hypertension, heart attack, stroke. All of these categories really have an effect on what the complications can or will be. One study that did a very good job of differentiating each of these risk factors was one completed by Gregory. One of the things that made the research more difficult was there were some studies that were very in-depth. However, they only covered post-procedure complications with a specific vascular closure device, such as angioseal and MINCs. This somewhat limited some of the researchers in how they viewed different closure devices because they were only looking at a specific closure device such as MINCs or angioseal, which there was a picture of earlier in the presentation. I would like to continue information gathering by speaking to more interventional cardiologists, more interventional radiologists, more general surgeons, so that you can get a basis for what they believe and what they have had experiences with, and asking them where they get their information on this subject, because there's a wide range of views when it comes to implementing a vascular closure device. The benefit to this is asking what their opinion is, asking what research they have viewed, so that research can be taken into account whenever you are doing your final presentation to really relate to them on best practice. Ethical considerations, benefit and harm. As previously detailed, there are advantages and disadvantages of using a vascular closure device. Advantages include quicker ambulation times, quicker discharge times, and less likelihood of a hematoma. Some of the disadvantages include an increased risk of retroperitoneal bleeding. The patient should be knowledgeable of all of these risks and benefits before the procedure so that they can make a decision on whether or not they want a vascular closure device as part of their care. Only physicians that are comfortable using the selected closure device should use it during that procedure. There are several different brands of closure devices, such as StarClose, AngioSeal, and MINCs, all of which are different and all of which require education. The physician should feel comfortable enough with that device before the procedure. In addition to all of these, patients should be monitored post-procedure for risks that have been detailed, such as retroperitoneal bleeding. While this is a low instance with manual compression and vascular closure devices, the risk still does exist. The patient should be monitored for an adequate time period, usually an hour to 2 hours, before being discharged. Another ethical consideration is persons without the capacity to consent. It's important to remember that these patients will be receiving conscious sedation or general anesthesia and will be in no fit state to make a decision about their health care at the end of a procedure. Patients therefore need to be educated on the risks and the benefits of using a vascular closure device before the procedure. It's important that the patient understands the risk and the benefit because you want them to have a say in their care. This is one of the things as nurses that we can do to advocate for our patients. At times, a vascular closure device is not indicated when doing a procedure. It's important that the patient knows that it was at least considered before the procedure, even if they were not able to have a vascular closure device inserted. Possible grant sources for this evidence-based practice research study would be the American Heart Association. Their mission statement is building healthier lives free of cardiovascular disease and stroke. Our mission drives everything that we do. They have a proven track record of providing funding to organizations that do evidence-based practice research. Included in this presentation was a study completed by DIHU, which received funding from the American Heart Association to complete a study on the feasibility and efficacy of vascular closure devices at North Shore University. They also have an easily accessible grant application process, which can be found online at the American Heart Association website. The conclusion of this study is that vascular closure devices have shown a decreased risk of most post-procedure complications, especially hematoma, access site bleeding, and vascular occlusion. However, by 2 of the studies, vascular closure devices were found to have an increased risk of retroperitoneal bleeding. One of the drawbacks with the literature that was reviewed was that there was a lack of randomization. In an ideal setting, patients would be selected to either have a vascular closure device or to have manual compression. But in this instance, it's very important to note that these are real people that we are doing this study on. So it's important while we complete our research that we keep in mind what is best for the patient that we are working on at that juncture in time. I think it's important for us as researchers to continue reviewing the literature that's published, but I also think it's important for us to create an environment that promotes thinking and finding out facts so that we can become better informed. I would like to do this by using the Iowa model of evidence-based practice because this model really gives us an outline and a method with which to be accurate with our findings, from finding the trigger, which we have already identified as vascular closure devices, and their implementation in patient care. These procedures are high risk, high volume, and high cost procedures that we should be informed on best practice so that we can have the best possible outcomes for our patients. A team comprising of members of the cath lab, interventional radiology, and the OR would be needed in order to make an undertaking such as this possible. These are the references that made this presentation possible. I hope you now understand more about vascular closure devices, the risks they pose, and the benefits that they give patients. Thank you for watching it, and I hope you enjoy.